All right, so some of you know me, some don't. I'm Daryl Fixer. I work at Shoreline part-time, and I'm a firefighter paramedic at Paris Island. That's my full-time job. While I'm here at Shoreline, the reason I came here was to keep up my skills, and two, because at Paris Island I don't get as many calls, and two is so I can start the critical care ground unit. So that's what I'm working on right now. So the ventilator, how it came about. In the last 6 months, we've had 3 patients die due to paramedics not knowing how to work a ventilator. 2 of those could have been preventable. One that I know because I talked to the state, they said the patient was coming out of the ER and the paramedic didn't check his oxygen and the patient died because of lack of oxygen. The second one, the cardiac monitor failed and they were in the ER. Both these patients were in the ER, and they decided to transport right on out into their truck instead of saying, stop, let's get a new monitor, and the patient died. So that's why they're having to do an in-service, and every paramedic in the state is having to do this. So it's not my thing. They just asked me if I speak. You got anything, Greg? All right. Let's see. So you have spontaneous respiration versus mechanical ventilation. You have natural breathing, and it's a negative inspiratory force where air is pulled into the lungs. You have mechanical ventilation. It's a positive inspiratory pressure, and air pushes into the lungs. So that's the difference between us naturally breathing and putting on a ventilator. Mechanical ventilation. There's 2 types. There's negative pressure and positive pressure. It can be invasive and non-invasive. Early negative pressure ventilators were known as iron lungs. The patient's body was encased in an iron cylinder. It was negative pressure that was generated. The iron lung are still occasionally used today. I've never seen one in use. I've seen iron lung at Colorado University Hospital, but never in use. And that's what they were. That's how big they were. When the polio came out, this picture was taken in 1953, and it was in California. Yeah, we didn't have ventilators in those days, so they encased you in there, and you sat there, and they had this mirror, so you can kind of look at yourself. And you laid in there, and you slept in there, and you stayed in there. That's the way you breathe. And so all those are mainly kids because they had the polio outbreak, and that's what happens. And they literally have nurses go down and check on each one, and then that's how respiratory came about as well. So negative pressure ventilators, intermittent short-term negative pressure ventilation is sometimes used in patients with chronic diseases, like I said, polio stuff. The use of negative pressure ventilator is restricted to clinical practice. However, because they limit position and movement, you saw how big they are. We tried to put one of those in the back of the ambulance. Today, we only focus on positive pressure ventilators. Indications, it's acute respiratory failure. If they're having ventilator or perfusion mismatch, VQ mismatch, diffusion defect, right to left shunt, and alveolar hyperventilation. Decreased inspiratory oxygen, acute life-threatening or vital organ-threatening tissue hypoxia. So those are indications why we would put them on a ventilator if they're not able to maintain their airway as well. So a lot of people know this. More diesel is not the answer. Go as fast as you can, or pedal to the metal. A lot of people will just throw them in the back, bag them, get them there as fast as they can. And we'll explain why it's not always good. I've had, over the years, I've been doing this, I've had paramedics say, oh, well, if I don't know what I'm doing, I'll just bag them all the way. Well, that's not a good, I mean, you can bag them for emergency reasons, but just to bag them because you don't know how to work the equipment because of disservice to the patient. Let's see. Blood gases. Most of you learn at paramedic school. Now they're even teaching in advanced EMT now. That's how much. Anybody not learning blood gases? No, so everybody knows. You remember it?
That's another question.
Yeah. So when you go there to the hospital, ask the respiratory, ask the nurse, hey, what's the last blood gas? When was it taken? You know, if it was taken 2 days ago, hey, can you give me a blood gas more recent? Make sure that I'm taking this patient out. He's got good ventilation. And most of the time on the charts or in the lab, it'll say high or low, and it's got indicators for you. But pH normal is 7.35 to 4.5. If it's less than 7.25, that's an indication to put them on a mechanical ventilator. PaO2 is less than 60 millimeters of mercury, put them on a ventilator. And if it's PaCO2 is greater than 50, they go on a ventilator. So what is a mechanical ventilator? It's a machine that generates a controlled flow of gas into a patient's airway. Oxygen and air are received from cylinders or wall outlets, things that the gas is pressure reduced or blended according to prescribed inspired oxygen tension, which is also known as FiO2, then delivered to the patient using one of many available modes of ventilation. And the reason why I put that up there is there's controversy. We have the auto vent. Most of y'all heard the auto vent, the little orange little box with 3 little knobs and all that kind of stuff. And we'll go over it in a couple slides. But in South Carolina in September of 2018, you can't use the auto vent no more for inter-facility transport. You can only use mechanical ventilators, and that's why I bring that up so people understand. Classification of positive pressure ventilators. There's 2 types. Well, there's 3 types actually, but ventilators are classified according to how the inspiratory phase ends. That factor which terminates the inspiratory cycle reflects the machine type. Now, there's no way in 2 hours.
Sorry. Did you say this year, September of 2018, the auto vent is not to be used?
Not to be used for inter-facility transport. Yep. Only can you use it for 911 calls only.
Oh, wow. Okay.
So if you go pick up a patient and you're taking them from hospital, you have to use the or a ventilator that has alarms and that. Yep. But you cannot, because you don't have no alarms on the auto vent. You don't have, when we go over the forms, when I talked to Rob, he's like, how can you fill out your form? You can't get all those numbers. You have to fill all those numbers in.
Where's the form at?
Oh, I got it.
I was gonna say, I've never.
Yeah, I'll show you. Yep.
So I've used the
I've
form.
used
They've
it.
been out for a while.
Yeah, but in September is when he said it kicked in. And he said, if you look at your protocol on page 63, it talks about ventilation. And in the regulations, it talks about what a respirator is, which is the auto vent, and what a mechanical ventilator is. And that's why I gave you the definition. So if anybody challenges you, ask you, say, hey, this is what mechanical ventilation is. And like I said, I can't teach you, there's no way I can teach you what I learned in respiratory school, and there's no way you'll be the most expert after coming out here in 2 hours. You'll have to work on it, and you can learn it, and it's not that hard. After a while, you'll be like, oh, this is not that big a deal. But you want it's your credibility, because when you start saying, hey, I don't know what that means, I don't know what this means, the credibility shot, and the doctors and the nurses and the RT are going to say, well, should we send this patient with this person? So that's why. They are classified as, there's the 3 types. There's pressure cycle ventilator, volume cycle ventilator, and time cycle ventilator. And the difference of those are the volume cycle, that is when you inspire, is terminated after a preset tidal volume has been delivered by the ventilator. So that's what a volume cycle is. So I'm going to give them 500 tidal volume. That's all they're going to get. Once it gets 500, it shuts it off. Does that all make sense?
And that's preferred, right?
No.
I know hospitals almost always volume.
You'll see. Yeah. There's a difference between, and I'll explain a couple slides down what's the difference. I prefer pressure, and I'll explain why. All right, the ventilator delivers a preset pressure, and once this pressure is achieved, inspiratory occurs. So why would I want pressure over volume? This gives a volume, right? I'm transporting the patient, and it more affects me when I'm flying on the aircraft, but it's still even on the ground. I'm giving you a volume of 500. You have a weak lung. You can pop a lung a lot easier with volume than you can with pressure because it's only going to stop. So if you get a high pressure lung, you ain't going to pop a lung because it's only going to go to 45 and that's it.
I got you.
So
But
that's
pressure is harder to calculate, isn't it?
No,
No.
it's not that bad. Time cycle ventilation. Time cycle machines are not used in adult critical care settings. They're only used in pediatric intensive care, so we don't have to worry about time. But so you have volume and pressure. Those are different modes. You have PCI-RV, you have AC, PRVC, APRVC, CPAP, SIMV, all these modes. And each, there's 20, well, one time there was 26 ventilators out there, company-wise, and each one has their own acronym. So you can see when I was in respiratory school, the nightmare I had to learn all these different codes for different. Draeger has their own, but they might be the same, but they're different because they can't copyright them. So we're going to go over the ones that affect us on these ventilators. You'll see a yellow one and a white one. I'll try and go get one of the ventilators in a little bit so I can show you once we get the lights back on. So that you can use assist control. You can set it at pressure or volume. So assist control is used a lot of times if I'm going to knock your respiratory drive out, but I can set it to pressure or volume. SIMV, you have pressure or volume as well. We have CPAP on our machine, and we have bi-level support, which is pressure support plus CPAP. And you have non-invasive ventilation, which is CPAP and bi-level. Those are the non-invasive ventilations. You all know how to do CPAP on the ventilator? I know we use the ones that hook up flow meters, a lot easier, all that kind of stuff. But you know you can. Did anybody know you could do that? Okay. Because like I said, I don't know what all you got taught.
I don't know how to set it up. Are we gonna go over how to set that up on our phone?
Yeah, and I've got to get a circuit because I don't have a mask or a circuit. So
I have one.
you do? Okay. So you have modes. You have tidal volume, and these are some of the settings on the outside. So when you're looking at it, you got tidal volume, your respiratory rate, inspiratory time. That's the time it gives to deliver that breath. PEEP or CPAP, pressure support, you have flow, how fast you want that pressure or that volume to go into the lungs. You have pressure control, patient trigger, how hard it is for them to trigger the ventilation. And on that note, patient trigger, the ventilator, we have a microprocess ventilators. The auto vent is a pneumatic. So I have to suck all the oxygen or all the air out of that tubing to make that thing trigger. If I got microprocess ventilation, I only have to breathe about 2 to 3 centimeters and it kicks automatically. Manual inflation, you can hit manual, like if you're wanting to give an extra breath, or if you're going to give them a breath because you're going to disconnect and hurry and, move them over, however you want to do it. That's what the manual inflation is. FiO2 is how much oxygen you're giving, and it's a percentage. Maximum time, and then you have flow and auto lock function where you can hit lock, and so that way you won't hit any buttons when you're going down, bumping it or anything like that. It won't change the settings you have. Anybody know about dope? Anybody heard of dope? Mnemonic? All right, it's in your protocols. Mnemonic for dope, you can help you remember the most common causes of post-intubation hypoxia or deterioration. And for that, displacement. So you're going to check the tube for displacement. If it went to the right main stem, did it come dislodged? It wasn't taped down good, it came out, and now it's in the esophagus. So that's going to give you at least an alarm on your ventilator. Obstruction, check your ET tube for obstruction, mucus plugging, or a kink in the tube. If you have a bacteria filter, they can vomit, they can go in there, and they can clog this up, and so you got to change that out. If you have them on for a long period of time, they can get a lot of condensation. It can plug them up. If you got a HME, which we'll talk about, the HME has got like it's to help with humidification. So if your HME has got a whole bunch of junk in it, same thing, or if they've gone into that or the secretions, they can do an instruction, you just got to change it out. Pneumothorax, that can be a problem. Get an x-ray and listen to lung sounds. Equipment failure, just disconnect the patient from the ventilator and bag them manually. It very rarely happens with mechanical failure, but just know that's the mnemonic that they want you to know. I threw it in there. So just think, okay, it's alarming. Why is it alarming? So my high pressure alarm is going off. Go back to obstruction. So these are alarms on the ventilator. We have high pressure airway alarm, low pressure airway alarm. Low pressure, it could be, does anybody know what was set off the low airway pressure alarm?
Usually when we're trading from one main, like the portable to main, it goes
Yeah.
off.
Yes, because you
Simple as
drop. What about pneumothorax? Okay, because I'm giving them a tidal volume of 500, and I'm only getting a return of 200 or 100. So the vent's saying, hey, wait a minute, where's all this air going? Is it come disconnected? That can give you a low air pressure alarm. Plus, you'll get 2 other ones. But knowing that, look at it. The alarm, like I said, the paramedic, and I don't know where it was, up in Charleston area, somewhere up there. The patient ran out of oxygen, and it kept alarming. All they did was kept silencing the alarm.
Could be mucus too. Like I had a
Yep.
patient I took to Knoxville every 15 minutes. She
Yep.
had to be suction or it was gonna go off.
Yep.
It's like clockwork.
Yep. So that can be, and backup ventilation alert. You have low O2 source. Like I said, it's got alarms and say, hey, my O2 is low. O2 is low. You have low air source. We don't hardly ever use air, but we can. We blend it for babies mainly. Device alert, and you have critical battery alerts. So when the batteries get low. How long does the battery last? It's in the ventilator.
A long time.
3 hours.
I messed with that one for like 5 hours and it was still like that.
It's so live.
Yeah.
So it's good to know that, right? Because if your battery's going low and you didn't plug it up or they forgot to plug it up, all right? Will the ventilator work on infants? How small can I go for these ventilators? It won't be there. Nobody know? Okay. Your battery will last 7.5 hours. That's at 100%. If you have it at 60%, it's the same. If you run it on air, means you turn it to 21%, it'll last 7 hours. So rule of thumb is it lasts 6 hours. You always put an extra hour and a half on there. So just round it off or round down to cover your high. All right, so that's your battery life. In that paper I passed out, those are the specs. It's on that thing, so you know. You don't. I'm just letting you know where I got it from. It's from the company. Anytime we get a new ventilator on that, you want to learn your specs, know the ventilator because somebody can challenge you. Ventilator, it can help adult and children up to 5 kilograms. So if there are 3 kilograms, we can't use this ventilator. Or 11 pounds. That's the criteria that came off that sheet. So you need to know that. You get a premium call, oh, shoot, we can't handle this one. Rob over at State said, hey, please put this in. So I did. It's just disclaimer. He's like, if you don't know what you're doing, stop. Call for help or have somebody else come to assist you. You'd be surprised how many people don't ask. And then also, like I said, those 3 people that were killed, 2 of them, they were in the ER. They could have said, hey, time out, time out. My cardiac monitor just crashed. Let's wheel him back in the room, hook him up to the monitor, and let me call for another ambulance and bring another monitor. They didn't. They put him in the back of the ambulance and drove off.
don't wanna interrupt,
Yeah.
but I know for a fact that lady who runs Coastal Respiratory Therapist,
Yep.
she's also the head lady for Hilton Head.
Yep.
And
I
she
met her-
has
I met
no
her.
problem with us calling and asking the respiratory therapist what to do if you should have a problem. So if you ever have a question, you can call Hilton Head or Coastal, and they're very familiar with our beds.
Yep.
Just there if you need it.
That's where I got the HME and the bacteria filter, because I went started today.
Yeah, she's very nice.
But, so that kind of leads on, okay, now I'll explain. I'll go to the next slide and I'll explain. Do you have a cardiologist hook up your cardiac monitor? So why would we ask respiratory to set up our ventilator? Because I just told you, if I go to respiratory and say, hey, can you set up my ventilator? They're gonna set it. They don't know how to set it up. So I'm gonna send this patient out with my patient to that hospital, and they don't even know what they're doing, don't even work. So you just lost all credibility. They're gonna say, this person doesn't know what you're freaking doing. The other thing is, when I was a respiratory therapist in the hospital, I had numerous times, I had paramedics or people who didn't know, or even flight nurses, hey, can you set up my ventilator? I had no problem setting it up. But if I set up that ventilator and you leave the hospital, I'm responsible till you get to point A. So that's a big liability. And then the respiratory part, they finally came out with a memo and a policy. We were not allowed to touch anybody's ventilators because of the liability. It's a risk management and all that kind of stuff. But yeah, she does know the ventilators. We talked today. But you want to own it. If you don't know what you're doing, stop. Let's get somebody that knows what they're doing. Because if you go in there and say, hey, I don't know how to work this thing, but can you hook it up? Well, if you don't know what you're doing to hook it up, and you're driving to Savannah or wherever, an hour drive, and the ventilator starts acting up, and you don't know how to set it up, how do you know what to troubleshoot? So that's why they don't really want you to be asking, learning. That's what we're trying to teach today. Capnography, it's a good tool. Everybody should be, inline capnography should be done, so that way you can,
That's a regulation now too, they have to
Yep.
do capnography.
yep. Oh, let's make sure I have what. But yeah, so yeah, so you have capnography devices. You know that if, say, you need to borrow one from somebody else, and they say, hey, we got a LifePak 15, just know that the 12 and 15, they both work together. So you don't have to worry about that. But you have your inline for intubated, and they can be used on King Airway or LMAs and all that. Or you have the nasal capnography. And it will tell you, if you put it on there, if they get dislodged, if they get, like you said, you had to keep suctioning a lot, it will show that on your capnography. So if you start seeing, hey, they're entitled with 35, now it's down to 20, and they're coughing and all that, you can say, okay, it could be secretions. So clean it out, and if it goes back up, you know that's what it was. There's a capnography tracing. Is there a problem? So, yeah. So know how to read capnography. I could spend hours on that, but there's no way I can do it all in 2 hours. So we can do another class some other time. Charting, things that you need to be charting to CYA yourself, what size of tube and where it's at. You know, 7.5 and it's 25 at the lip or the teeth. You need to document that because you get to the other facility and they say, no, it was 29 at the teeth. You can say no. Then they got dislodged on you guys, not me. Good rise and fall of the chest, and then you auscultated all the lung sounds. Vital signs every 10 minutes to include entire CO2. What numbers you get back from the ventilator should be charted as well. So if I'm given a rate of 500, I'm given a tidal volume of 500, and I'm only getting 200 back, there's a problem. I need to look at it, find out what's going on, And so you want to be looking at what the patient's giving back, what you're giving to the patient. Make sure the singing facility has filled out the state day-ahead transfer form to include the third page. I'm gonna go back to it.
Can I ask you a question about
Yep.
time? I've never taken a patient out of the hospital and it not be like, and it be perfect, 35 to 45. It's always like 55, 60, and the respiratory therapist is like, they're fine, go. What,
That's on the heart of it.
yeah, on
Yeah.
the, well, actually on the hospital's bed too. Like,
On
it's
the
always high. So what,
Well, it depends on, what are they there for? They, COPD patient?
I'm just saying in
or-
general, I've never
Is it
had
good?
anybody that's 35 to 45 come out of the hospital. So I'm just trying to like, if I'm documenting that 62 and the hospital has told me, hey, they're cool, like, how am I supposed to fix that? Or am I supposed to fix that? If they're, they've been fine on that the whole time. Or they've been
If it's
62.
fine, it's just, you gotta look at that, especially if it's at 50 and then all of a sudden it drops.
Mhm.
That could tell you, hey, the pneumothorax could happen. I can tell you that, hey, it just got disconnected. Have you ever had the pulse ox lay on the counter and give you 98%? The ventilator can do the same thing. You can actually disconnect the ventilator and put it off the side and just get enough flow by it, and they can be totally disconnected and not breathing, but the ventilator won't even alarm. And your tidal CO2 will drop. I always put nasal capnography on anybody give morphine, fentanyl, any narcotics. I automatically put them on that because my tidal CO2 will go down and you'll see the respiratory rate go down after giving fentanyl. And you'd be like, oh shoot, that sucker's going down. And so that'll go down before your pulse ox even goes down. Your pulse ox can read 98%, but, and you know how that is proven, that even in a house fire, they'll say 98%, but they got a CO2 of 60. Same thing, if you put them in the tidal CO2 and you start seeing that number drop, that's when you want to be cautious. So there's your, but anyways, the day-ahead form, there's a page 1, page 2, and page 3. The page 3 is the ventilator one. I know at Hilton Head, they'll fill it out even for just a regular transfer, but on the ventilator, if they're not going by ventilator, they'll just put a line through it. But that has
You
to
don't know anything about these.
Even if-
Hilton Head, Hilton Head, I've seen them when I had to pick up a patient. I was taken that was on a cardiac drip or something like that. And I was going to Savannah, and she filled it all out except for that ventilator, and she's put a line through it. But so we can print some and put some on each truck, but just make sure that they got to have them filled out because the state's looking at these, especially the vet ones. That's what they want. I'll try to bring it up so I can tell you.
Well, you know what I've done over at Compton, because I already gave them a stack of,
Yeah,
and they don't use them. And if I was to bring one out, then they look at it like it's Greek.
That's what they did to me.
How to throw it out.
Yeah, but the same thing.
I heard people say to them,
Yeah,
I was like, I don't even think it would be for
and
that.
I can fill it
They're
out
supposed
for
to have
them.
a copy book, so I
You know.
understand.
well, it says right there that the facility is to fill it out, and it says RT, NP, PA, MD, or DO can fill out that part, and you're to fill out the other part in the square box. If you don't do this, DHEC's gonna get you. So it behooves you to at least know about it. I know it didn't get passed on very well. He's the one who told me about it, because I didn't even know about it. And then I started researching that from Rob, and he's like, yeah, so all you do is go type in South Carolina EMS ventilator transport form, and you can find it. It's really easy after that.
Oh, yeah.
But this,
So I'm responsible for this part.
right,
So respiratory could be responsible
That's
for this
correct.
part.
Yep.
But again, he's looking at it like it's Greek. So at what level of a person needs to go in there and say, here, when you do your MTAL, your transfer form, also do this. I fought for years over here with Coastal just to get a copy of the transfer package, and they're like, you're the only one that ever asked for a copy of the transfer package. I gotta have it.
right. You have to have that filled out if you're gonna transfer. If they're on drugs, you gotta have that filled out.
I only did it if you're on drugs.
Yeah, I got a cardiac drip and all that.
I was
I gotta
gonna
have it
say,
filled
do
out.
you want me to sign something? They're like, what? I was like,
The paper. I'm
Yeah,
supposed
some
to
of
do.
them.
the transfer form, maybe? Okay.
So,
And, you know, God help you if you go up to the floor and you're picking one off the floor, and I'm out of the ICU, off the floor.
we had that, I had never ran into this in my whole entire career, and I've been doing this for 27 years. But we went to a dialysis center, and the nurse goes, I won't sign that.
Oh,
You
yeah.
have to sign it.
Yeah.
I'm like, you're taking things, oh, no, I ain't signing nothing, come to me, sign, and I'm like, what the heck is this? So all you have to do is, if you've got a problem issue, go through Scott, and if it don't get addressed, then what you do is you call Rob or somebody at the state, because they're over at the hospital as well, and say, hey, I have an issue, problem. And they will go in there, Mitch or
Right,
whatever.
I'll talk to Scott when they come out with these and say, one of your boys, Pitco, whoever, send them down there
Right.
and tell them.
Yep.
Here's this, attach it, fill it out.
I talked to the respiratory director today for both Coastal and Hilton Head, and we talked about some of that stuff, and so I told her about that form, and so we're gonna try and schedule a date, because I explained to her, she goes, we don't understand what EMTs can do, advanced and paramedics, and so if they're not a cardiac matter, BOS, and they don't understand the difference, and
Dispatch don't even understand
I know.
because they just list stuff off.
that's a whole
And
nother
hospitals
subject.
like, yeah,
I
yeah.
know.
I know, I got asked if I could do selection the other day, I was like, what?
Yeah,
Actually, you can't do that.
I can do that. I don't think Coastal and Hilton.
and I can throw the person under the bus, but I had a call. He was in Savannah. You were in Savannah, right? The other night, on Monday night?
Sure.
We were coming from Charleston. I got to Yemassee, and Joe called me and says, hey, I got both my ALS units in Savannah, and I've got a Coastal to Hilton Head
Yeah.
that needs to go straight to the cath lab, and he's unstable. So I told my partner, I said, light it up. She goes, we can't go light this Arsenal Hospital. Light it up. I'm like, yes, we can. So I argued for like 15 minutes, and finally got her convinced to light it up. And we got about 10 minutes out, and they gave it to the customer. But
And
that's just education and stuff like that. And that's the same thing here. You know, it's just educating people to understand what needs to be done. And that's why the state is requiring every medic to go through a 2-hour ventilator class to make sure everybody's on the same page. It sits in there, in that box. It says, our equipment is able to meet the above settings, and I attest to my competency to operate this equipment during transport. So when you sign that, you're saying, hey, I know how to work the ventilator. But if you look, and it says ET tube size, depth, right here, respiratory rate, actual rate. On an auto vent, can you get the actual rate from the, nope. Can you get, you got a title on, you got FiO2, inspiratory pressure and peak, does auto vents have peak? Nope. So you can't get, so that's why he said you can't use auto vents, because you can't get any of these settings because they don't have alarms. The only time you can use auto vents is if you're on 911, he's at call to the fire department, he responds to a house, and he works a code, he can hook up the auto vent to go from the 911 emergency call to the hospital. That's it. You cannot go from hospital to hospital. And if you see anybody using it, you're supposed to let the state know, because they're starting to crack down on people. Also, Mitch will come by. He was going to try and come by tonight, but he's in Charleston. But Mitch is going to come by, and when he does our audits, and he's going to look for that sign-in sheet. So make sure you're all signed in. If you're not on there, then you can get in trouble.
So, okay, let's say we have all 4 ALS trucks out running with vents.
Yep.
They cannot throw an auto vent on a truck and go take a vent call. That's illegal.
That's illegal.
And Scott and everybody else is aware
He
of
knows.
that.
I told him.
Okay.
I said, if you don't believe me, call Rob, because Rob told me.
So they're all on our trucks, but
I
a
know.
lot of them is backups.
Dave says I'm trying to pull them off.
You're gonna pull the vents off the trucks.
Auto vents, yep. You can't have
Oh,
auto
auto
vents.
vents.
Yeah,
Okay, I
yeah.
was gonna say,
No,
you
no,
can
no,
pull
no.
the vents off your
No,
trucks.
no.
They're moving in the second.
That's why they
And
put
it's
the
like you-
AHP 3000. And there's other competitors, without saying their name, that are still using the auto vent. And that's why I've already talked to Dr. Raymond over at Beaufort Memorial Hospital. I know him. I got his cell phone number, and I explained to him what we have and what capabilities. And I said, hey, we're trying to start a critical care unit. And he gave me a hug and said, thank God, thank God. Because if everybody, I don't know if y'all know this, but when you fill out that form that I gave you, it says MD and all that, and their orders and all that. Are you aware that the doctor that signed that is responsible from that hospital until you get to the arriving hospital? Most people didn't know that. So that's why, doctor, when you say, hey, doc, we got critical care line, okay, what do I say with you? You guys are more experienced, more trained. So that's why they want you more trained and more on these ventilators, because we have the capability and other people are looking at us. The director, like she said, Hilton Head, the fire department, she said they have to take respiratory out of the hospital if they transport a vet. We don't want that. We want to
Do
be,
they have the vents that we have? Or do they have to take the vents out of the hospital?
I don't know, she didn't say. But she just told me the respiratory has to ride with them. Because
Yeah.
they are so scared of what ventilator. We don't want that. We want those vent calls. Those vent calls pay money. And if we can grab all the vent calls, then you can get more money per hour. You can get power stretches. We can get more equipment because we'll get more money.
Okay, now without being argumentative, yeah, go back to the part about running code to the hospital.
Yeah.
I got dispatchers saying, want me to run code around the corner for preterm labors, all kinds of BLS calls.
Who can make that call?
Huh?
Who makes that call?
Well, I make that call all
There
the
you
time.
go. The medic makes the call.
All the time, but why can't we stop the dispatcher from doing that? I mean, you're an hour out, and you're an hour out, and they're like, run code to the hospital.
They can't make that call.
Run code to the hospital for a trauma patient
They're in
that,
a facility stable.
It's not
When they called and said this patient is going straight to the cath lab, it's unstable, I told Joseph, we're lighting it up. Because you're in a facility that cannot do cath lab. Cardiac is muscle and time, and they're gonna, and I said, we need to go. When I did critical care, we went licensed to the hospital, licensed to the hospital, and all of our transfers were all licensed to the hospital. Because we're doing critical care, we got 5, 6, I've had 12 drips taken, ventilators, balloon pumps. So when you start dealing with all that, and so I said, so Scott asked me, he's like, well, what was the big deal? And I said, well, because they're unstable, I made that call. And he said, I didn't know. I committed to it. Finally,
right, but how far out were you?
was it young? 95.
So, I mean, and they called county.
I
before you
got literally 10 minutes away, and they canceled the 6 of Jasper.
Yeah, Jasper is always like right there. So
Yeah.
that's what they should have done to start with.
But Jasper, I don't think has anything for all of us. The last time I checked.
I thought personal, or like
But they
competitor.
can use AutoVent, right?
Not
Yep.
hospital.
Not hospital, they cannot use it. Only 911, so if I go to somebody's house, and I'm working a code, and I'm out in the county where it's just me and you, I can use the auto because there's not enough hands, there's not enough people. But I cannot, if for inter-facility transfer, you gotta have that form filled out. Hospital to hospital, hospital to another rehab facility that has ventilator capability or nursing home, whatever, has to have the ventilator like ours. That's it. That's the only way you can do it.
So if they get to, let's say the competitor gets to that hospital with the auto vent right now, are the hospitals aware that they can't use that equipment right now? Are they responsible if they use that equipment?
When I'm in the hospitals, I'm pulling the docs, hey, this, and I pull up pictures on my phone, like, hey, if you see this vent, can't use it. Only you can use this vent. We've got that capability. Here's my card. And so I'm
We should
getting,
just walk that ventilator into the
I know.
ER and just-
now,
Well, I know the respiratory therapy.
yeah, Hilton Head knows we have it, Coastal has it, Buford knows we have it.
I'm talking about the wrong vent, the auto vent, like take that in, this is
Oh,
what it
yeah,
looks
I know.
like.
I'm gonna, like I said, Hampton knows that, hey, don't call. So I've been getting it out there as much as I can, but
I wasn't even, I just used it like a month ago.
Yeah, I know,
I
that's the
just,
first
you
time I heard it.
know, I didn't know.
and like I said, I got that straight from Chief of EMS, Rob, said, look at your protocols. Your protocol says what a difference between a respirator is and a mechanical ventilator. You can only use mechanical ventilation.
Okay, where are the protocols?
It's in your regulations or it's in the truck. But he
Yeah,
said-
hard updated, anything? No.
We gotta print them out, we gotta print the new ones out.
Okay.
Because the new
That's
ones
what-
required us to have our dosage on there.
You find them on continuum.
yeah,
Yeah, without the dosage, but we have ours with the dosage on there. I have it on a flash drive. We just
like
have to
if you
put it-
got Mitch's phone number, you know, it's called him that and say, hey, I heard this in class last night. He was gonna try and come, so then I could have just said, hey, Mitch, am I right? But he said, I wanna come so bad, but I'm in Charleston by the time I get there. He said, you guys will be almost done. But, that's why I wanted him to be here. And I tried to get Scott to get our medical director here too, so you can ask questions. Because it is fun. I don't even better. Anybody need a break? Let's see.
maybe I'm getting ahead of the game, but
Yeah, go ahead.
the propofol that they send, can they send, okay, so let's say they send the one vial and the one vial is a quarter full. What they have been doing with us, or at least with me, is they won't replace the entire vial prior to departure. And I said, well, we're going to run out before we get there.
Right.
So what they do is they hang a secondary vial so that when I'm done with the first vial, I can click on the second vial. Is that legal?
Technically, no.
Technically, no, but
No.
that's what they've been doing.
I know. It's supposed to be per the protocol, what they said. Because I asked the question, I said, well, when I came from Alabama and we didn't carry fentanyl in our truck and had morphine, but the blood pressure too low, I'd say, hey, doc, en route, I got a patient, a 14-year-old kid that burned himself. Can I get fentanyl in case I need to give it? And then they would give me the fentanyl and sign it out to me. I would transport the patient. And if I never use it, I'd come back and give it back to the nurse. They put it back in the system. That's good.
Mm-hmm.
So I asked about that. And this is what Mitch told me. I'm just telling you, I'm word for word. Mitch said, we will look at that because if they're a critical care paramedic, that's maybe something that we can let them have capabilities of doing, changing out stuff and do a little bit more past a regular paramedic scope. So that's what he said.
So let's say borrowing Ativan for a pediatric seizure patient, that's still illegal.
Right.
Okay,
If
so
it's not on your,
it's
So
not in
we
our
do that.
bag, but they just gave it to me.
me.
They told me if I filled out this, whatever this drug transfer sheet is, they
Yeah.
said if I fill this out, that they'll hand me a vial of Ativan and they'll send it with me a pediatric seizure patient.
I asked Mitch, and that's what he told me. He said, I said, can they give me a Tomadine, subsequently? I don't have RSA per se on our trucks, but I need to keep them down or not coronium on. And he's like, as we speak, he said they have to hang up a fresh bag if it's gonna run out, that you cannot hang it, and it's gotta be hung up before you leave the facility. That's what he told me. I understood. So he said, well, he was going to push avenue is if you got your critical care paramedic, now you will be able to go ahead and carry propofol and be able to do a little bit more, even though Scott don't have it on the truck.
Right.
You can get it from the hospital and say, hey, can I get some propofol? And you can hang it and run it and do it. So that's what he's looking at, trying to get past through Rob, but I don't know.
So even with the propofol and everything, but like if we go to Ativan or something like that for pediatric seizure, you hand me a vial and say, you give this for this kid because you don't carry it. And if they fill this out, that's legal. Then handing me that vial of Ativan.
That's what he
That's
told me now.
not, in 61-7, we can't hand you anything.
Yeah, that's what I'm saying.
So what are we supposed to do if you
Use first set.
Yeah, you got first
But they
step.
told
But
me
I've
I can't
had-
use it.
I've had doctors tell me,
Yeah.
no, you do not use Versed. I want you to use
But tell them
Ativan.
always
So
have it
we
first.
have, we have,
I have
We
to,
can't take
do you run into that problem a lot?
all the time.
So go out, do you have Scott and the
Yes.
attitude? Oh, okay. I'm just asking.
And then Scott told me that it was legal if I did this.
That's
If
what
they filled it out.
Mitch said no. I mean, I asked Mitch.
Well, I believe you. I
Yeah,
believe you.
I mean,
I'm
I
trying
literally
to
asked
get
him,
the
because
correct.
I said, hey, these people are gonna come up with questions, so I started asking
Yeah.
questions. to make
I just
sure
want
was
the
on record.
legal way to do this.
All right, perfect example. I thought, and I know it's in Alabama and Arizona, everywhere else in it, but do you know an EMT can transport a ventilator patient?
Oh, thank God.
Did you know that? I was like, are you kidding me? And I said, the reason why I'm asking this, Mitch, or Rob this morning, I said, I've got an advanced EMT in Colleton, works for Colleton Fire and Rescue, with EMS, and she transports a home ventilator patient all the time. He goes, yeah, home ventilator? Basically transport that. That doesn't make sense. He said,
Yeah, we
it's
do
their
it all the
home
time.
vent, it's their home vent. they can
Ventilator
transport.
transport.
No, we always sent a medic unit for them to use.
Not always.
No, not always. I was a basic unit, even though I was a
Yep.
paramedic.
Isn't that crazy?
Basic
that
unit.
They moved you as a paramedic.
Yeah,
Keep
Yeah.
your seat
But
after
technically-
one.
yeah, keep and see to take it all the time.
Isn't that crazy? But if you were the owner of the company, why would I want to send a basic when I send a medic unit? Because now I can charge for ALS 1 or 2, even though it's a home vic. So you're actually cutting yourself. But I'm just letting you know that I was pretty scared of that. I was like, are you serious? They don't even learn vents in basic or even advanced, and you're gonna let them.
Probably do like the basic, right?
What's it just like,
I asked Ron. I said,
we got I don't know if we
he says, got to be their home vet. So I bring up that question is, so you got a patient you're going to pick up at the hospital that's got a home vent, and you're not trained on it, wouldn't you want to switch them over to your ventilator? Because you're trained on that ventilator. That's what I would do. More liability if you go home with their vent. And yeah, they know how to work it, but what if they code? You know? Just some food for thought, is what I'm trying to say.
Nothing to worry about.
So,
Basically, the theory of just getting the job done doesn't work anymore.
no, they keep,
So if you hear, get on scene, nope. not
Wait,
on
and see what
scene.
happens. It doesn't work anymore.
Oh, yeah.
I understand how it's done.
Usually if you tell them you can't take it.
So that's what we were in Mexico.
but they do get it. You know, that's what
You
they,
signed it.
because I mean,
There, you know,
Don't forget.
Right.
have you used it?
I can bring it back.
I remember the last time that was a big fuss. We went to Hilton Head, and got a PT the patient, and we didn't take the Ativan. They were like, oh, we ain't seen them since the hospital. We didn't make them first bridge come off the foot, and that patient started sleeping. Never passed.
Oh, I know. Wait a minute.
Like, not anymore.
I think it's crazy because I'm like, we're allowed to administer it. We had it on the truck, so why can't we get it?
And
to
we used to
somebody?
carry it too.
I know.
Yeah, we couldn't regulate the temperature.
Yeah, that's true.
Oh, that's what you're thinking about?
Well, no, that's why we stopped.
That's why
carrying
I
it.
know,
carrying
but
it.
because it costs money, have to put weight on it. I got a call for that. I already fixed. I've already told them I buy a solution. I'm fixing that. You can buy for $100 an insulin box that plugs in the truck. You put it in insulin like little refrigerator thing. I said that's one. And it's $100 and then you don't have to throw it away every time. Or two is the paramedics come pick up their bag. It's inside here. Takes it to the truck. When they get done, put it back. And it's temporary.
Oh, so, I mean, keeping on, like, let's say that unit runs for 24 hours.
You come in, get the bag. You take your bag out. And then
So every call you come in and swap.
no,
it
not
out.
every call. Just
At the end of the shift.
at the end of the shift, you would
Swap
take your
back
bag in.
in.
And have that bag in. That's what we do at Paris Chatham, they have, the bag is full of
And they
ALS
carry
stuff.
Valium
in the
right
truck. Yes. Paris Island, we got ketamine coming, fentanyl, morphine, Ativan, Versed, and we do RSI there. So every agency's got their own little quirks and doing stuff. Charting, all right. So also things, so lungs were, make sure you chart, you check their lungs or listen to their lungs prior to moving them. Once they get on your stretcher, check, listen to their lungs. And then when they move to the bed at the other hospital, chart that. Because that's where they'll throw you under the bus saying, well, you transported them when you got them here, tube disc became dislodged and all that. And how that, I know that happened was in Phoenix, Arizona, a Phoenix firefighter was getting manslaughter charges because he innovated esophagus, but he said, no, I innovated, and it was a big controversy. Who could blame? Was it dislodged en route? Did it get dislodged from moving? So I'm just telling you, you might want to chart. Outlets in the lungs, they were clear prior to moving. Once they moved, ET tube still at, like I said, it's up to you how you want to chart. HME for long distance shoots you into Knoxville. It's a dry gas. Oxygen is a dry gas. So anybody know about HMEs? So HME, it's got like a sponge inside. So it's different than a bacteria filter. So you may know that's an HME. There's the bacteria filter. Not the same. But that HME will, when they breathe out that condensation, it collects it and it actually helps so your secretions don't get thick when you do long distance transports. And all you gotta do is say, hey, respiratory, can I get an HME? HME means heat mixture exchanger, and that's all it is. Something simple, grab it, say, hey, can I get 2 of those? That way, if one gets clogged up, you got another one backing up, especially doing long distance transfers. Get 2 or 3 bacteria filters, always good to have extra. Like I said, in case they throw up in the ventilator and it goes in there, clogs it up.
How long is that one last?
That one will last 24 hours.
I'm showing it here.
Here's bacteria filter. Y'all know about the bacteria filter, right?
You have to get those from the hospital. We don't have them.
Nope.
They don't come attached to the circuit.
Nope. Yeah.
You do not. You have to get them from the hospital.
Yeah.
Find out hard way.
Well, we can order a box of them, but not the hard.
Yes, you can.
When you get the intubated patient coming out of the ER, it's already hooked up, it's in line.
But if you're not paying attention, it will just hook up to the vent without it, but you want to have it.
Yeah, because that protects, especially, you got tuberculosis and all that, that's gonna go into your vent, and the next patient's gonna get it. So that's why you want a bacteria filter. And you just get it off the vent. But you can always say, hey, respiratory, can you give me another one? And then throw it in a bag or whatever, and keep it with you in case something goes down. Like I said, if they throw up in there or whatever. Any questions so far? Up to now? I don't know if this will play or not. I'm trying to get this thing to play. How does that? Anybody know how it is?
Critical care transport is a jet and critical care ground ambulance
There's a
service
bell there.
providing transport between healthcare facilities. Transport for neonates under 1 year of age is available and staffed by neonatal nurse practitioners and registered respiratory therapists. The adult team transports patients 14 years and older who are cared for by ICU registered nurses and registered respiratory therapists with physicians available 24/7. The expertise of UAB's 1,000 plus faculty positions is available to the transport teams. Critical care transport has many specialized capabilities. For adult patients, these include intracranial pressure monitoring, hydrant, intra-aortic balloon pump therapy, bedside laboratory testing, ventricular assist device therapy, rapid video laryngoscopy, nitric oxide therapy, high flow oxygen, and ECMO management and cannulation. For neonatal patients, there is a fully equipped isolate, high frequency ventilation, nitric oxide therapy, phototherapy system for jaundice management, and active cooling. All flight requests are received and managed by registered nurses or respiratory therapists. There are 3 ambulances designed with safety in mind and advanced medical capabilities required for critically ill patients. The newest ambulance features a liquid suspension system, providing the most comfortable ride for patients, as well as enhancements to braking, traction, and communication to improve overall safety. UAB's jet can accommodate 2 patients and fly in weather that helicopters cannot. A built-in liquid oxygen system, along with dual medical air and suction systems, provide redundancy. Transport is also available for less acute patients on the ventilator who are moving to or from long-term acute care facilities. Patients can be moved between any 2 facilities when the patient meets medical necessity and nearest facility criteria or otherwise with payment arranged. Critical care transport has been accredited by the Commission on Accreditation of Medical Transport Systems since 1999 and has been featured in their last 5 best practices publications. Critical care transport, patients' secure link to their healthcare needs.
All right, what are we watching?
So far we learned that automated is illegal.
You got some chocolate.
Guess we should just take them up the truck.
Still there.
He said me.
No, let me get it. I'm hungry.
Wing stop is actually really good. This one today.
The one in Bluffton?
Yeah.
They just opened it.
It's so good.
I didn't know it was there. I was just trying out today.
First time.
First day, though.
Any questions? Any questions? All right, so if you got piece of paper, I'll give you a phone number.
Did you find the vent circuit?
There's one connected there.
I got this.
Is that tank?
There's no regulator on it.
How you want me to go get your regulator?
I can just do 21%.
Okay.
I just need to get up. So area code 334 406 5148. That is my phone number. To preferably probably text me because I might be on a truck or going to do somewhere. So if you run into ventilator problems or you can't remember something, you can always text me and I can call you and try and talk you through it. There's a patient side, and then there's an O2 delivery side on this ventilator. That's Dr. Dreaming from Grey's Anatomy,
Oh, yeah.
and that's me when I flew for UAB. McDermott? I don't.
No, it's emeritus something. What's emeritus?
Derek,
A neurological problem too. The irony.
Nope, it was hilarious.
All right, so you have the connection. There's a blue grayish type one. Where the bacteria goes on that. In your vent.
He's been intubated for quite some time.
Cold that thing goes down.
That's just survive, you know.
There's a blue, clear, and then a big tube. Big tube goes to big hole. The blue goes where the grayer the blue is. And then the white goes where it's the silver letter. So that's how you set up the circuit. This right here, little port is hooked up to nurse alarm. So if you work in a hospital, you can hook it up. And then if the ventilator alarm, it alarms at the nurse panel. So we don't have to worry about that. You have your DI, your disc system plugged in for your oxygen. You have it here, so 12 or 13 kilogram patient, which we don't have any trucks anyways, blender and oxygen, and we can blend it down so the oxygen is not as concentrated. Anybody know what that is? The full. There's like a little thing, it's got a little cover on it. Wait a minute. You know what that means? All right, so you know how you have you can plug in the flow meter and then plug into make a long extension. Well, if you plug in this to the oxygen, hook it up to your regulator, you can, as long as it's 10 liters or less, you can do it that way as well.
Why would you?
Say you're in the hospital and they got theirs is already hooked up and you can plug it in here, plug it in there, so you switch it over, it's already over there. You got this, you forgot this. You know, I mean, just so you know, I'm just trying to make you more educated. That,
No, I was wondering about it when I was
Yeah.
reading up on it. Like,
So wait a
why
second.
would you use that?
So it's right here.
Yeah,
you
but
see-
what are we talking about with the
You know, like, I don't have,
It's low flow.
Oh,
So you can put just
oxygen too.
just like, it's like. the
instead of the green hose.
Yeah.
But it has to be less than 10.
Yeah, it says right here, it says 10 PSI max, 10 liter maximum, or liters per minute. So hook up 10, put it
The
in
other
here.
day, I tried to put it there, and it kept popping off.
Oh, really?
I thought I had too much O2 going to it. I turned it down.
Mhm.
I looked at the thing and I seen 10, I turned it down, kept on popping off.
Off this?
Yeah.
Oh. Well, that's what it said. I don't know. The auxiliary power, which we don't have to worry about, and you have the regular power in here. Don't cover up this. That's where the air comes in.
They said that had to be changed so often.
Yeah, there's a filter in there. And then these are supposed to be calibrated at least once a year. Or it's ventilator depth, and this has to be automatically pulled and checked. You got your adult and your child. You turn it on. FRP is 21%. So it's on adult mode. You can hit the child. Just set your settings. This is your vent settings. Here's your alarms. This is these are your vent settings. Your alarms. And then it will tell you what the patient's doing, giving it back to you. There's your manual breath. O2 conserve. Did you hit the O2 conserve? Try that next time. Hit that because I think that's.
When you put it on.
Yeah, I think you did that.
Is that high?
Yeah, I think I did try that.
Is that high pressure one? Because it goes
Low
off
pressure.
every time. Okay.
Yeah. there's
Oh,
lines
it's
on
Low
it.
not,
pressure.
it's not on there yet. Okay.
Yeah, because I couldn't disconnect it.
Because it seems like it goes off for every patient I have.
If you see that,
Yes, quick.
the vent is not alarming. Well, history. That's what I was trying to explain to you.
Fixed it.
Okay, so I've seen this happen where they actually came disconnected and it was just barely in there. They were getting enough flow. It wasn't.
So the vent's not alarming. It's a mannequin. Like,
it's
it
a
doesn't
mannequin.
know.
Yep. So. Any other questions, problems?
Sure.
Yes.
So I had a bypass patient the other night, the 5 p.m. and switched over to,
Why would we do that?
because it sensed that the patient was apneic,
There we go.
and it did it. But the thing is I didn't know that it would do that.
Yes, it's a backup.
But it switched over, switched back, but most of the time it didn't switch back, and I manually switched it back. And
But yeah,
stuff.
that's the backup mode. So that's what's. All right, so assist control. You know what assist control is and what's SIMD mode? Does everybody know what that is?
Go over it real quick.
All right.
It's been a
Assist
while.
control. So assist control is I set the rate of 12,500 tidal point. So and I'm going to set it for inspiratory time, 1 minute, 1 to 2 ratio. So every minute, 500, 500, 500, and you're like you're trying to breathe, and boom, you get slammed with the breath. That's assist control. You're actually breathing. So the patient's now like this, and it's trying to, they're automatically kind of buck and all that. So if you switch into SIMV mode, what it says is, hey, I'm going to step back for 60 seconds. If you breathe, I ain't going to breathe for you. As soon as you stop breathing, I wait 60 seconds. Okay, I'm going to give you a breath. And it goes back to assist control. But if you take another breath, it just resets itself. It keeps resetting itself. And it's letting you breathe on your own. So it's more comfortable for the patient.
All right, so it'll continually swap back and forth.
Yeah.
Because it continually swap back and forth.
Because it's that backup mode because it's signaling after 60 seconds, they're not breathing. I gotta go to where if I put you on CPAP and plug you up to the flow meter, if I'm not paying attention, they can stop breathing if I'm not paying attention.
Right.
There's no alarm. So
I have plenty of alarms.
oh yeah, this is an alarm.
I was beat out.
I try working respiratory and IC, try to figure out what's going on. I know. But I'm just trying to let you know, the reason why Scott wanted to do it was one, not because of state, but he wants us to be more, knowledgeable because he don't want us to go out and look like idiots. And you go, hey, I don't know how to work this. Hey, can you help me? That's why he wanted you to, hey, let's learn it. Just like you learn the cardiac monitor, you don't go ask cardiologist, look at the cardiac monitor.
And if those settings are 5 and 10, I didn't dump a lot of oxygen.
Right.
But I think at 5 over 15 or 15 over 5, it really starts dumping oxygen.